from Kuwait. Well, you know my name. I live and work in Kuwait, and I'm a pediatrician. And I guess I was one of the really, the old people that was involved in palliative care in India. And most of my work was actually at Tata Memorial Center, Mumbai, where I was, I guess, one of the few people that was instrumental in starting the MD palliative medicine program. But I've subsequently moved to Kuwait, been here for over a decade, and now work really in pediatric complex and pal care. So thank you for having me here. I'm going to be talking about neurological symptoms in pediatric palliative care, and I do apologize that it's a long presentation, but I'm going to kind of leave the reading work to you and maybe like just highlight the important points as we go. Do feel free to ask questions and post your comments in the group. I guess either Smriti or Vinila will be able to look at them and we can address them towards the end of the talk. So here we go. This is where I live. This is Kuwait. We are frightfully close to the Persian or the Arabian Gulf, just a stone's throw across the sea from Iran. And these are the Kuwait towers. I'm going to be showing you some pictures of Kuwait as we go because otherwise the presentation is really going to be tedious. So there are several symptoms, neurological symptoms in pediatric palliative care that we come across. And I am going to use some non-cancer examples because it's the children with non-oncological conditions who often have really complex and long-standing neurological symptoms with a very high impact on quality of life. And it not only affects the child, it also affects the family members and the caregiving professional teams. And sometimes, or rather quite often, these symptoms tend to be quite difficult to manage. There are several more, but I'm going to focus today on seizures, pain and neuroirritability, dystonia, spasticity, and delirium. This is a little girl that we are currently caring for in our inpatient unit. We have a 20-bedded complex and inpatient palliative care unit in Kuwait. But the problem is there is no real clarity and medico-legal support for do not resuscitate, which means that a family could choose to have full resuscitation even though, the child clearly has a prognosis that does limit their survival. Anyhow, this is a little girl with Down syndrome. She's 3 years old. She also has an atypical rhabdoid teratoid tumor, and she's received her treatment in the US. She was able to tolerate just one cycle of chemotherapy and then developed severe reactions to it. She's had a VP shunt and she's had some resection. These are her recent scans. She's currently on oxygen by nasal cannula and she had some seizures that were controlled on levetiracetam. Any quick other symptoms or clinical findings that might come to your mind? I'll just give you a few seconds to think about it. And then I'll run through some of the things that she actually does have. Do feel free to, post it in the chat. That would be wonderful. There are no signs of raised intracranial tension currently. Does she have pain? I'm going to come back to this case vignette when I talk about pain because she does have a very interesting symptomatology around the pain. She has obesity related probably to having received high-dose steroids for a very long time. I'm going to move on to what is called severe neuroimpairment or SNI. And this really refers to a group of disorders where the CNS of the CNS that results in motor cognitive impairment and medical complexity. While the impairment is permanent, the course could either be progressive or static. Talking about medical complexity, this, I guess, is a growing concern in the pediatric population as medical technology now makes it possible for children to live longer. So children who would not have survived are now living for several years, and most of them are what are called medically complex, which means their conditions are chronic. They tend to have a significant burden from the disease that impacts the quality of life. They have significant caregiving needs. And in most scenarios, they are dependent on some kind of technology to keep them alive. So, whether it is some kind of ventilation, invasive or non invasive, or some kind of feeding support, and so on. So, these are the children with medical complexity, and often they make up a significant chunk of the pediatric palliative care cohort as well. Moving on. So, a general approach to managing all neurological symptoms in palliative care. These are some of the things I did talk about this. The symptom burden tends to be high, multiple symptoms, and often one symptom impacts the other. Say, for example, if a child has dystonia and pain, it's probably that one is making the other one worse. The experience of the pain not just depends on the pathology, but also the age, cognition, the language capability of the child, and their ability to express the symptom. Sometimes it's really difficult to even pinpoint what the symptom exactly is because they are complicated symptoms and the child is not able to self-report. And in those situations, a time-limited trial of medication may be necessary to uncover what is really going on. So, as rule of thumb, approaching these symptoms in children with SNI is, first of all, to identify what the symptom is, then to understand what are the provoking factors and are there any factors that make the symptom better. Are there any medications that are contributing, and could we do something around those medications? Let's talk first about seizures, because these are fairly common towards the end of life. Up to 90% of children with complicated neurological conditions will have seizures at some point. They're distressing. And what I would like to emphasize is that the standard seizure management that works for an acute pediatric scenario may not work in a child who is receiving palliative care, especially as their disease progresses. And the approaches might have to be quite innovative and different. So these are some of the fundamental elements of caring for seizures at the end of life. What are the goals of care based on clear communication between the family, the different caregiving teams, and so on? So is it complete relief of seizures? Because sometimes these children have such severe encephalopathy that often, their receptor physiology is very skewed, and what would work for other children may not work for children with severe neuro impairment, especially if the symptom hasn't been controlled for a long time. So how aggressively are we able to control, and what could the end result of that be? What is the prognosis, short-term, long-term? What is the prognosis of the disease condition? What are the benefits versus the burdens of any given treatment? Is monitoring the drug level mandatory? I would say almost never in the end-of-life care scenario. And very, very often, almost always, we are using these drugs in an off-label fashion. So either for conditions for which they are not approved, or in dosages and formulations for which they are not approved. And there is the doctrine of double effect. I don't know if you've covered ethics in the course so far, but double effect basically means that we do an intervention for the good of the patient, but inadvertently we could have side effects that are not in the best interest. Say, for example, we use a very high dose of midazolam and the child could become very sedated and not be able to interact at all with their family. So that is double effect. Now, even more an even more stark example is in an absolutely imminently dying child, we might end up using doses of medications to relieve their suffering, say from pain or seizures or dystonia. But those doses might inadvertently foreshorten life. And this is the doctrine of double effect. Basically, it means that we are doing something respecting the principle of non-maleficence and beneficence, but inadvertently it could lead to a side effect that is not anticipated or intended. So that is the doctrine of double effect. I'm not going to delve even more into that, but happy to take questions later on. 6-step approach to managing seizures at the end of life. And this comes from the Association of Pediatric Palliative Medicine guidelines, which are fairly recent. First of all, identifying the children who are at risk, being prepared, having an advanced care plan, defining what is the seizure, what does a seizure look like in this child, what are the drug-related interventions, what are the supportive care interventions, and then review and revision going forward. This one is unreadable, but the components of this diagram are really important. And if you look for this reference online, the APPM seizure guidelines, it's quite easy to find. So I would urge you to all do that. I'm going to go through a little bit in detail over here. Identifying the children at risk. So based on, the conditions, what is the underlying disease? Say, is it a seizure syndrome? So yeah, clearly these kids would have seizures that are difficult to control. Is there anything that is compromising the seizure control? They are not able to keep their medicines down, they are vomiting, or they have an intercurrent infection, so on. To have an advanced care plan, especially if the place of care is not the hospital. So has the family been told what to do? Do they have the medications to administer if the child has a seizure, and are they actually able to give it to the child when the seizure occurs? What is the seizure activity? We are currently caring for a child whose seizure sounds like a dog's bark. That is the seizure. Nothing else happens. So these children who are very neurologically abnormal tend to have very different kind of seizures. So what is it? Is it pain? Is it seizure? Is it dystonia? Is it GERD? What is it? So these are some of the differential diagnoses, and we often need to observe closely, rule out, give a therapeutic trial, and so on. This per se is the management. As in acute peds, the mainstay of management first line is benzodiazepines. The route is different. So buccal or nasal midazolam is preferred. We could use rectal diazepam, but perhaps not as preferred as the buccal or the nasal route. Lorazepam, if there is an IV line in situ, but if the child is at home, then this may not be the case. Two doses of benzodiazepines 10 minutes apart. Third dose could be paraaldehyde. If not, and if in the hospital setting, we could, load with half a loading dose of phenobarbital. Or we could use levetiracetam at 40 mg per kg as a loading dose, even if the child is already on Levipil. If that's not helping, we would consider giving a continuous infusion. Usually the first line is midazolam. If not, we could give levetiracetam. If the child is already on levetiracetam, then we give the whole 24, we give the full oral dose in the same amount as a 24-hour IV infusion. If not, we could give phenobarbital. I have more experience of using phenobarbital because it's an older drug. It is long-acting. It is also anxiolytic, and it treats a number of different type of seizures. I'm going to talk to you about two rather uncommon drugs that are not even for palliative care physicians. These are rather uncommon to use in their practice. And we've had a few patients for whom these were effective. We had a 10-year-old with a neurodegenerative condition and a very difficult to treat epilepsy syndrome. He was on almost all drugs that are available on the market. That list is, I think, 7 or 6 drugs long. This child was admitted to the PICU for a pneumonia, long-term ventilation, had a tracheostomy, and was then was transferred to us for supportive care. Continued to have focal right upper limb seizures, and there was quite a lot of argument around should we treat, should we not treat, is it distressing? I felt it was distressing for the patient because he was constantly fitting. It was status epilepticus. And the drug that we use, and this was recommended by neurology, was chloral hydrate or pedicloral. Not a very commonly used drug, but highly effective. I'm not sure GABAergic action and so on, but highly effective. We kept this patient on that for several weeks, and then Kuwait ran out of stock of chloral hydrate. So what did we do then? We moved to ketamine. Ketamine is rarely used it's not very common to use ketamine, but intravenous or subcutaneous infusions of ketamine are sometimes effective in refractory status epilepticus. I'm just going to leave you with that information. But if you indeed do reach a point where you're considering chloral hydrate or ketamine, do involve your pediatric neurologists because we need that experience. Moving on to the next symptom, which is pain in children with SNI. You might have perhaps covered this topic in the last lecture. Can someone tell me whether this has been done? Have you covered pain in SNI? Anyone? I can't see. Maybe someone can type in the chat. Okay, 1 new, 2 new, 3 new.
No,
Okay, it's not been done. All right. So I'm not sure whether this baby has neuro impairment, but I thought the head looked a little small and could perhaps be syndromic. So here we are. We talked about what severe neuro impairment was, and I mean you will have the presentation for reference. These children often tend to have very severe pain almost on a daily basis. It often gets unrecognized, and these children remain untreated for their pain for days, months, if not years. And these are some of the challenges, because how do we know that this child is in pain? Their CNS is abnormal, which means that they're most likely to be hypersensitive to pain, and they might experience pain differently and more severely than other normal children. The other thing is that a stimuli that may not be painful in a normal child might be excessively painful in this child. They often undergo a number of multiple surgical or medical procedures, which means several iatrogenic causes of pain. And a child who's undergone a procedure is likely to have more pain, one from the experience, and also because sometimes there is a neuropathic component that gets worsened with repeated procedures, especially with abdominal surgeries. Coming to the assessment, these are the things to generally look out for. I'm not deep diving into any of the scales here, but just what are some of the things that could tell you that the child is in pain? Some kind of vocalizations. The child's face shows that he's uncomfortable. The child might be clenching their jaw and grinding their teeth. So if a child is doing that, it's really important to ask what is going on. Consolability, the interaction, either they might be seeking too much interaction for distraction, or they might be very withdrawn. Difficulty in sleeping, movement, changing in the tone, clenching of the fists, tachycardia, sweating, change in color, breath holding, crying, and some kind of very atypical features, which means that we really have to rely on the family caregivers or the nurses who are seeing them on a long-term basis to describe what those things are. These are some of the nociceptive causes of pain in children with SNI. Unfortunately, we've had this more than one time on a ward where we've had children with SNI who suddenly become extremely uncomfortable, especially when they are touched at a particular point. And skeletal survey has shown pathological fractures. I mean, clearly these children have a reduced bone density, very high risk of path fractures. They are in an abnormal posture, poor muscle tone, difficulty in reporting. So these are some of the things to look out for, stark as they are. And it's really very heartbreaking to see these kids go through that much pain. So running through the list of nociceptive pain causes in these kids, musculoskeletal, related to tone abnormalities, muscle fatigue and immobility, related to the gut, and Dr. Smriti will be talking about this. Iatrogenic, we talked about that. Then the other common causes of pain in a child, otitis media, dysmenorrhea, appendicitis, dental caries, non-specific stones, urinary problems. They are at a higher risk of urinary stones because, again, their diet is abnormal, or they are bedbound, so they're not ambulatory. And kids who are on ketogenic diet have a higher risk of gallstones. It could be related to some intracranial, device or so on, or it could be just a simple headache. Then there are certain medication toxicities that might mimic what's pain. So serotonin syndrome looks like a child who's hyper alert, not looking well. Related to SSRIs, tramadol, fentanyl, linezolid, ondansetron, metoclopramide. The last three probably the more commonly used drugs. Then malignant neuroleptic syndrome showing extrapyramidal side effects, rigidity, autonomic dysfunction. Related to neuroleptics, metoclopramide are abruptly stopping anticholinergics, tardive dyskinesia, and akathisia. So it's worthwhile thinking about, is this a neurological symptom? Is it a drug effect? Or is it something that's being exacerbated by a particular drug that we are using? I don't know if there are clinical pharmacists on the wards, but these could be useful folks to work with here. These are some of the behavioral pain scales. So one of them is FLAC, commonly used one, and it's there for your reference. I'm just going to talk about one more, and I'm going to refer back to the little girl with Down syndrome with ATRD. So I asked her mom why she thought she was in pain when I was doing my rounds. And she said to me, it's because she is moving her right hand, which she normally doesn't move. And if you listen carefully, she is moaning. And I did, and she was moaning. And I asked the mom, how severe do you think it is? And, on a scale of 0 to 10. And she said, I think it is 7 on 10. If I hadn't asked mom, I would have missed that, because movement of just the right hand, I would have considered that's probably a focal seizure. So are we looking at a seizure pathology versus a pain pathology? I wasn't able to hear the moaning till I listened clearly. So I think the point I'm making is that listen very carefully to the caregivers and the nurses who know the child better. Do not disregard, because it's really hard to figure out what the symptom is even. The treatment approach. So treat whatever contributing factors there are, the nociceptive ones, so infection, fracture, so on. If there's clearly spasticity, consider a muscle relaxant. Autonomic dysfunction responds well to gabapentin, clonidine. Sometimes morphine, propranolol might be required. GI symptoms, I love that point. Refer to Dr. Smriti's lecture. And try to, make sure the child can sleep well, because sleep deprivation will worsen the symptom of pain. Just taking a quick breather here. These are postcards from Kuwait. The first one is actually it's kind of the view of that is the Persian or the Arabian Gulf, depending on what side you're on. And yeah, that's a sunrise, which I caught a couple of weeks earlier. Moving on to now, what is neuroirritability? And this is a rather important symptom in children with severe neuroimpairment. It kind of looks like pain, but it's a little distinct from pain, because it's clear in the definition. It's a recurrent condition of irritability and agitation in a nonverbal child with disordered CNS in the absence of a clearly identifiable nociceptive or an inflammatory source of the pain. So it's not a nociceptive pain. It arises from a disordered CNS itself. So it is a type of a central neuropathic pain. These are some of the contributors to neuroirritability. A child who's, emotionally upset, has an acute intercurrent illness, has a neuropathic pain, autonomic dysfunction, disordered CNS basically, is worsened by delirium, drug toxicity, or certain drug withdrawals, or, somatic stimuli, which could be visceral, sensory, or vestibular. So anything that really could annoy or irritate this child might worsen neuroirritability. Therapeutic approach, treat the treatable. Focus on the non-medication approaches, which is calmer environment, reduce social and psychological triggers to the extent possible. Use a multidisciplinary care plan with the child and the family's involvement. These are some of the non-pharmac interventions that work. Music therapy is known to be evidence-based, and it does help children, as does touch therapy, um, time in the pool, or aromatherapy, and so on. The medication of choice are the gabapentinoids, which act on the GABAergic system. If not, benzodiazepines can also be used in neuroirritability, especially as for episodes of neuroirritability as rescue medications. And usually you would use a short-acting one, such as midazolam. Clonidine is another excellent drug to use, and in other cases, we could use methadone, risperidone, and so on. Moving on to dystonia. So dystonia is sustained or intermittent muscle contraction with abnormal repetitive movements or posturing. It is often unrecognized. It is very commonly accompanied by pain, which makes it a rather important symptom to look out for and to treat. Status dystonicus is a rare syndrome of dystonia, often related to a fatal prognosis. There are certain non-motor manifestations of dystonia, and those could be pain, dysautonomia, bladder or respiratory dysfunction. Might have an impact on sleep, sitting, and other vegetative signs of stress may be seen. Management approach: treat the exacerbating factors, whatever they may be. Consider benzodiazepines, again clonidine and gabapentinoids, because there is evidence to show that the management of neuropathic pain will independently reduce the symptom of dystonia. The management of dystonia per se is usually the first line are anticholinergics such as trihexyphenidyl or benztropine. We could add some benzodiazepines in addition for what is dopamine sensitive dystonia, and often this is less common in pediatrics. We could give a trial of carbidopa levodopa, a trial to see whether there is an improvement or not. Again, it's very useful to bring a neurologist into the picture, and they will often give you good inputs. Non-pharmacological deep brain stimulation, or if it's a focal dystonia, consider baclofen and so on. Supportive treatments, physiotherapy, occupational therapy, and of course, ongoing psychosocial support. Going to touch briefly upon delirium at the end of life. Delirium is acute brain dysfunction with an alteration of the mental status, consciousness, cognition, with lack of attention, disorientation, disorganized thought and behavior. Again, probably underdiagnosed in children. This picture came a little bit later on. Anyway, postcards from Kuwait again. The types of delirium are hyperactive. It is less common but easier to recognize, is marked by agitation, restlessness, confusion, hallucinations, delusions, sleep-wake reversal, and so on. Hypoactive, where the child really seems apathetic or withdrawn, but may be experiencing hallucinations. Less common, it is more common, but often tends to be less commonly diagnosed. And the third one is mixed, so a child who's alternating between the two or has features of both. Causes, of course, caused by the primary condition, metabolic disturbances, infections, organ dysfunction, drugs such as opioids, benzos, and anticholinergics, or drug withdrawal. These are some of the assessment tools. I've put them there. Their reliability in children in palliative care who are at the end of life might be a little bit difficult to they might not have been tested in these populations. They're often in the ICU setting, but at least they are a starting point to see whether the child has delirium or not. Management-wise, reassurance, ensuring the safety of the child. Some kind of environmental modification to make sure the environment looks familiar and quiet for the child. So, their favorite toy, their favorite blanket, photographs of family members, and so on. Correcting any reversible causes. Keeping clocks and calendars for the child to be oriented in time, if that is going to be helpful. Awareness of day and night, which means drop the blinds during the daytime, put the lights off at night. Mobilize the child, kind of to give them some kind of a routine. Limit the number of visitors if possible, the same nursing staff. Reduce the stimulation wherever possible. Management, if it's clear that some medications are causing delirium, then we might want to consider reducing or stopping them. But often some of the major culprits are opioids and maybe even some of the benzodiazepines, where there is a paradoxical reaction, or after the long-term use of benzos, often these are the medications we cannot stop. So then it would have to be a balanced decision between the continuation versus discontinuation. Then the decision of could you rotate the opioid or the benzodiazepine to some another one to reduce the side effect, or do we accept the side effect and treat the delirium? So depending upon the prognosis and the discussions with the family and the team, we could use any of these approaches. Generally speaking, in pediatrics, benzodiazepines are used as first line, unlike in adults where the first line would be an antipsychotic like haloperidol. The antipsychotics are also helpful, and these are haloperidol, risperidone, quetiapine, olanzapine. I am really familiar with using haloperidol rather than any of the others. It is known to prolong the QT interval, and again, depending on the goals of care and the prognosis, do we want to use haloperidol or not? Do we want to do an ECG or not? So these are some of the considerations. And I leave you with that postcard from Kuwait. This was us on a home visit where we did a little bit of extracurricular illegal activities and met some wild camels. I must say it was risky, and I'm not going to do it again. I don't know how we are for time. Vanilla, how are we for time?
Ma'am, is the session over to Shruti, ma'am? And there are some questions also in the chat, ma'am. So,
all right. Okay. Maybe Smriti wants to go.
Thank you. Would you like to take the questions first, or?
Let's look at the questions. I can't see.
So one question says there is a shortage of nasal midazolam, one, and another thing someone says she must have some dystonic pain. Only these two, ma'am, not so many questions.
Yes. Okay. Smriti, I'm going to pass that question over to you about the shortage of nasal midazolam because I don't practice in India, so may not be the best person to answer that.
Yeah, there are intermittent shortages, but by and large, I have seen that my patients have received nasal midazolam. The other, I think there are, this was probably for, was it for status epilepticus or was it for
Must have been.
some
Must have been,
other,
yeah.
was this, whether this was for like managing seizures at home or for some other reason? I think there are also other options we have of lorazepam, rectal diazepam. Those are some of the other options that we can use in times where we don't get nasal midazolam that easily. But usually, most of my patients have got it within a day or two of searching for it.
Yeah.
I think we can move on to. You can keep posting your questions in the chat. Dr. Manji can sort of look at them and maybe reply within the chat. And I'm assuming she will be there by the end of the session too. We will now move on to GI symptoms. As you must have seen, the way things are approached in palliative care is more symptom-wise and symptom management-wise rather than disease-wise, which is why you are suddenly like, there is a barrage of one symptom after another. And it sometimes is a little disorienting because you end up having to look at things from a different perspective than what we have been trained to look at, which is very disease oriented. But hopefully, these will give you a good idea about what you can do when faced with issues, because quite a lot of symptoms, especially GI ones, are drug associated. And so one of the commonest drugs that we will end up using in palliative care is opioids, and very important for us as we prescribe opioids to know what are the side effects and how one can manage them. So we will cover some of the pathophysiology also of the symptoms, some of the diagnoses behind it, and a bit of both pharmacological and non-pharmacological management towards them. This is some of the commonest symptoms seen both towards the end of life and also for children with life-limiting conditions who receive palliative care at home. So diarrhea, cachexia, constipation, vomiting, and to a small extent, ascites. The list of GI symptoms are, of course, longer. These are some of the other common GI symptoms in palliative care: regurgitation, cyalorrhea, hiccups, intestinal failure. We will also be discussing a few slides on GI dystonias because Dr. Manjari was discussing them in the context of severe neurological impairment. I will not be able to cover all these symptoms because that will end up being too many slides and we will probably run past our time. But we will try and cover as many as we can. And management principles are, yes, we need to establish the cause. You must have heard this multiple times in our lectures: treat the treatable or reverse anything that is reversible. That's one of sort of the basic tenets of palliative care. If this symptom is receptor mediated, choose the most appropriate receptor antagonist as well as the most appropriate route of administration, and this can vary at different times of the disease trajectory, whether the child is at the beginning of treatment or at the end of life, and of course review regularly. So starting with nausea and vomiting, one of the most common symptoms that we see in our day-to-day practice. Nausea is the unpleasant sensation of needing to vomit, and vomiting is the forceful expulsion of gastric contents through the mouth. The physiology behind this vomiting is that you can have increased salivation or involuntary retching that is the preceding event. After which you have synchronous contraction of the diaphragm, the intercostal muscles, as well as the abdominal muscles. There is raised intracranial pressure. There is also relaxation of the lower esophageal sphincter, and then this is followed by forcible ejection of gastric contents. If there is one thing that I want you to remember about nausea and vomiting, it is going to be this slide because it literally covers most of what we need to know when looking at a patient from a palliative care lens. The mechanism of action depends on what part of the body it has originated from. So if you have origination from the brain cortex, this is most likely an anxiety or anticipatory nausea and associated with most commonly, as you would have seen this, chemotherapy. The antiemetic of choice is actually an anxiolytic over here, and the neurotransmitters that mediate this are GABA as well as acetylcholine. Then you come to the vomiting center. The neurotransmitters here are acetylcholine, D1 and H1. The vomiting center actually coordinates the vomiting reflex, and there are some similarities in terms of medications with the chemoreceptor triggers. Let's go now to the chemoreceptor trigger zone. This is one of the most important causes or most important areas that triggers nausea and vomiting. We have D2 and 5-HT3 as the neurotransmitters here. And cause-wise, there are a variety of causes here which can be the problem. It can be drugs, which is chemotherapy, opioids, SSRIs, toxins, infections, and cytokines, biochemical such as hypercalcemia or uremia, and again a gamut of medications also which will be useful. So, when it comes to opioid associated, SSRI associated, we end up prescribing uremia associated also. We end up prescribing more of metoclopramide and domperidone. Haloperidol is used, it has a multifactorial effect, and ondansetron more so with chemotherapy and infection associated nausea. Then let's move on to the vestibular apparatus. This is a little bit more unique. There is a single neurotransmitter responsible. Most common cause is actually motion sickness, and so the antiemetic of choice will be an anti-H1 or an H1 antagonist. Then comes the gastrointestinal tract. Here, the causes can be either a tumor within the tract or a tumor pressing on the tract, causing partial or complete obstruction. There can be ileus because of multiple causes, and there can be constipation. The neurotransmitters here involved are D2, 5-HT3, and 5-HT4. And because there are so many neurotransmitters, you can use multiple agents for treating nausea or vomiting that originates at the gastrointestinal tract. So I want you to just sort of open your chat boxes. Let's go through some of these cases, and you can also give me what you think about are the causes for these cases. So just a short description. A child with medulloblastoma is irritable, is having headache, is also having vomiting. What is the cause for the pain? Yep, we already got an answer, raised ICP. That's correct. A child with severe pain started on tablet morphine 1 day ago and now has presented with vomiting. Possible causes? Drug-induced, opioid-associated, absolutely. Liver metastasis. Sorry, I'm just trying to change my... Yeah, tumor-related. Child is icteric, also vomiting, so the jaundice associated with liver disease, basically. Child with osteogenic sarcoma with a huge tumor mass with a wound around the shoulder and having more of nausea rather than vomiting. Possible causes? Anticipatory makes sense. Yes, infection related could be. Severe pain is also a good, yeah, that could be one cause also. There's one more cause in this situation that I'm thinking of. Cytokine related, okay. Can be due to the smell. Perfect, perfect. Okay, so this is basically what we have sort of discussed along with the management also. So a child with medulloblastoma, if raised ICT, then dexamethasone is going to be your drug of choice. For opioid-associated vomiting, metoclopramide and haloperidol are drugs of choice. In fact, there are many centers which routinely prescribe 3 days of metoclopramide while starting an opioid, while initiation of an opioid is happening. Child with liver mets, metabolic is the primary cause of the vomiting or the nausea. And for sarcomas with a huge tumor mass, the odor can be responsible. A lot of anxiety also can be responsible. And so actually here, managing the pain, dressing the wound, these are the aspects that will help with the child's nausea more than actually giving an antiemetic. Actually, in terms of for nausea for children, pharmacological therapy is quite effective, and non-pharmacological therapy, there are only a few pointers that one can share. So emotional state, smells and sights, all of these can be a cause of nausea and vomiting. So see if you can manage any of these and try and make any of these better. Smaller meals are usually tolerated better. Trying different food consistencies can help. Trying different food types in terms of sweet or bland, these can also help. So, by different food consistencies, I mean things like jelly, liquid, or something which is more crunchy. These are the different food consistencies that the family can try. Sometimes providing food at room temperature also helps reduce its smell and taste. Because you are going to be faced with a child who is not going to be eating much, you will have to try calorie dense feeds. So, I either including calorie dense feeds or including butter, oil, syrups, sauces in order to raise the calories. So, these are some of the non pharmacological therapies that you can apply. Moving on from nausea and vomiting to constipation. Constipation is difficulty in defecation, and that can be infrequent bowel movements. It can be small and hard stools, and it can also be actual painful evacuation of stools. So there is a vicious cycle of events, especially in children when it comes to constipation. You will have fecal retention, which can cause rectal distension. That will then go on to reduce the actual perception of food of stool in the gut, which will then move on to cause hard stools, pain during defecation. Pain will cause partial evacuation and impaction, and then you can have the eventual formation of a fecaloma. So, a stepwise algorithmic management of constipation. Start by identifying the cause. So, that will be a proper history evaluation examination, including a drug history and a physical examination. For non pharmacological changes, you can start by increasing fluid intake, providing a comfortable or a familiar environment, and introducing dietary changes such as increasing the amount of fiber in the diet. Then we come to pharmacological management. For children with dysmotility, intestinal dysmotility you are suspecting, and on opioids, stool softeners and laxatives are better than osmotic agents because there is already reduced secretion within the gut. So using things like docusate, these will be better, bisacodyl, these will be better than osmotic agents. For children where you are not suspecting opioid induced or dysmotility, osmotic agents can be used. I'm not saying that for children on opioids, osmotic agents are absolutely contraindicated because we do end up using them for them from time to time. But just be aware that you don't go into a very prolonged cycle of constipation and then you end up having giving osmotic agents for a longer period of time, and then there will be even further hard stool. For those, the other agents that can be used are lactulose, PEG, magnesium sulfate, and then you have treatment via the rectum. Of course, for those who are neutropenic, especially our hematology patients, it is not recommended to give per rectal or enemas or suppositories. But for other children, say solid tumors, non-neutropenic, non-thrombocytopenic, suppositories or enemas are the next option of treatment. And again, important, especially if there is a continued reason for the constipation, is to continue the bowel regimen. I'm not really going too much into drugs. Tirumala, we will come to this question maybe by the end of the thing, and you can maybe describe your case a little bit more. I'm not going too much in detail upon the doses of drugs. You can have the presentation later on if you want, and I'm sure many of you know already what are the drug doses that are used in this scenario. Okay, so case again. 10-year-old child with case of Ewing sarcoma of left femur, severe pain at the site of disease. Pain was managed by titrating morphine dose daily, but the child has come back with a colicky abdominal pain and constipation since 8 days, and laxatives have not helped. What have we missed? Thoughts? VCR-induced constipation. Okay, but I think that VCR-induced constipation also works well with for laxatives. Drug-induced constipation. I think that's what I'm trying to say, that we have ruled out drug-induced constipation. Any other thoughts? Okay, just giving it half a minute. Spinal involvement, that's an interesting thought process. Spasm, intestinal obstruction. Yeah, yeah, yeah. So lots of good answers there. Opioid-induced constipation, the effect on the bowel. I think that I went one case early. Okay, so this was more of a case of opioid-induced constipation. We did not end up giving a laxative for this patient. In palliative care, the maxim is that the hand that writes the opioid must also be the hand that writes the laxative. Otherwise, it will be the hand that is doing the per-rectal evacuation. So opioids, the reason why opioids are notorious for constipation is that while they will increase the circular muscle contraction, they will reduce the coordination of the peristalsis. So there is slow bowel transit, but there is also dehydration, and so there is reduced secretion of fluid and electrolytes within the gut. So you have a combination of slow bowel transit and dry hard stools. This is why osmotic laxatives are not so effective, because there is no scope for them to sort of gather fluid through osmosis in order to increase to improve the consistency of the stool and allow it to pass better. So opioid-induced constipation, while stimulant laxatives are a very good option, I have never reached a point where I have had to use methylnaltrexone, where I've had to use actual opioid antagonists to actually solve an opioid-related constipation issue. Maybe Dr. Manjari can also enlighten us to let us know if she has actually had this problem in the future. In the past and needed to rely on opioid antagonists. Okay, next case. I think I've already given out the answer for this one, but nevertheless, humor. A 12-year-old child with lymphoma, mets to the abdominal nodes, has come with complaint of vomiting since 5 days, constipation since 9 days, and abdominal pain. No relief with laxatives and ondansetron. This is not a child that is on opioids. So what do you think can be the cause here? Obstruction. Absolutely. This is the X-ray. And that brings us, I think, very nicely to the next symptom, that is intestinal failure. Let me just see if there is anything else on the chat. Yeah, it's the same. Okay. So, a definition of intestinal failure: a reduction in the functional gastrointestinal mass below that needed for digestion and absorption, and a child requiring greater than 50% of their calories by the parenteral route for greater than or equal to 28 days post-term. While there are many non-oncological causes for us in an oncology and hematology setting, it will be most likely bowel-reducing surgeries that will be a cause for intestinal failure. And some of the symptoms are bloating, abdominal distension, nausea, vomiting, and diarrhea, anorexia and fatigue, and seizures and tetany. Keep in mind that loss of more than 50% of the small intestine can lead to intestinal failure. And the management of intestinal failure is one of the reasons actually why I wanted to discuss intestinal failure here, even though this is not really a pure oncology kind of topic. There is also a lot of discussion in the palliative care world about how useful, how pragmatic, how ethical an approach is total parental nutrition for both children and adults. But here we are talking about it from a pediatric point of view. So the various things that you have to look at when it comes to TPN is the cost, of course, accessing a central line and having to keep changing central lines, requiring regular blood work. How will you prepare and store it? What are some of the adverse events associated with it, and how do you manage that? So, in palliative care, actually, we do use a lot of alternatives to TPN. One of the commonest ones is IV or subcut hydration. I don't think that subcut hydration may have been discussed previously. You may come across it in your end of life uh, session. Basically, what subcutaneous hydration is that you put in a subcutaneous line, and this can be a butterfly or a scalp vein, or it can even be a regular IV cannula. So, putting in a line like that under the skin allows for, and then connecting it to IV fluids allows for the child to receive some amount of hydration, some amount of nutrition, primarily in the form of glucose or dextrose, but it will allow to some extent. And I also feel that to some extent it mitigates the guilt of the family. But the caveat is that at the end of the day, it is an IV. The advantage of a subcutaneous line over an intravenous line is that you will not have to prick the child multiple times. It is inexpensive. You don't need. It is low tech. You don't need. You don't need too many various sort of machines, or you will need just some simple expertise in order to do subcutaneous hydration. Let me see. There is one question in the chat. Flow rate. So, usually for children who are above, say, 35 to 40 kilos, about 500 to 1 liter of IV fluids can be given through the subcutaneous method. I don't have the exact flow rate available now, and even the per kg rate for subcut hydration available now. But if I'm able to find it out, I will send it across to Vanilla and let you know. You don't need any special pump. If you have, basically, the idea is that if you have decided that this child needs about, so usually in a child who is malnourished, at the end of life, you are giving IV fluids mainly for as maintenance and not in the sense of actually building up on nutrition. You will give about 50 to 75% of what is the ideal IV fluid requirement for the child based on the weight. And so that is what you will give even in a subcut hydration. You can give this amount over 4 to 8 hours. It does not need to be a 24-hour. It does not need to be an infusion over 24 hours. In fact, in adults, they have managed to give about, I think, about 800 ml to 1 liter over the span of just 1 or 2 hours. But usual practice is 4 to 6 hours. You can give the decided dosage of IV fluids over. So, in patients who have either intestinal obstruction or intestinal failure, all these all these things are, we have to balance all of this. One is whether to give TPN. If yes, for how long? If we are planning to give it for a long period of time, till what endpoint? The other is whether subcutaneous hydration can be offered as an alternative to TPN. Then the other is whether to continue comfort feeds or not in a child who has intestinal obstruction or intestinal failure. I would say if the child is already on an RT, in order to drain the intestinal to help intestinal drainage. Otherwise, the child is having a lot of retching and there is a lot of secretions that are coming out. Um, you can continue the continuous RT aspiration and continue to give them comfort feeds at the same time, with the knowledge that this is not going to contribute to nutrition at all. So, very difficult to deny a child feeds at all. And so that's why comfort feeds sometimes help. And then the other ethical the other ethical aspects of TPN that one needs to balance is how much is this going to cost the family? Is this going to require them to stay in hospital rather than be able to go home? How are we going to be able to tackle the complications? And what is the potential burden of suffering here that continuing TPN and ensuring some semblance of nutrition, how is it actually helping the child in terms of being able to do some activities or being able to spend some quality time with their family? Let's see. We have a couple more questions. Subcutaneous route has a time limit. Is it feasible for the long run? So usually for 2 to 3 days, you will find that the line will stay. If you use an IV cannula and place it in the subcutaneous space and you kind of bandage it in a similar way that you would bandage a normal IV cannula, it's likely to last 2 or 3 days, sometimes even more. The other interesting thing about subcutaneous routes is that you can use the proximal aspects of limbs. So you can use thighs, you can use the arm, you can even use the trunk. So abdomen and upper chest, all these areas can be used in order to put in a line. So you are able to kind of cycle spots also, cycle where you will be able to put in the line. Rather than maximum rate, I would be more sort of keen on having an upper limit for maximum IV fluids that we are going to be giving the child. Okay, I think we're going to skip this because this is more related to intestinal failure. This was actually the treatment of the intestinal obstruction. I think that this slide got misplaced. So I'm sure you know most of the principles of conservative treatment of intestinal obstruction. You have to allow gastric decompression, so using either an NG tube or a venting gastrostomy for the long run. Avoiding prokinetics. Antiemetics are actually better here than prokinetics. In terms of analgesics, if you are thinking about opioid analgesia, the analgesic of choice is fentanyl because it has the least effect on the gut. And you can use either, especially if there is acute pain that you are trying to look at, then you can have a continuous fentanyl infusion running on in the background. The other anti-secretory agents, which can also double up for pain, can be hyoscine, and then of course you can have octreotide and glycopyrrolate to help with reducing the amount of secretions. Dexamethasone is quite commonly used in malignant bowel obstruction. You will not want to overhydrate. Usually, the maximum palliative care is hydration should be lesser than what you would do when you are looking to sort of fluid resuscitate or volume resuscitate a child, because the side effects of hydration kind of tend to be much more in palliative care children, because you already will be having some amount of third spacing going on. And then antibiotics, of course, for GI sepsis. So moving on to anorexia and cachexia. Anorexia and cachexia is actually a very interesting bundle of symptoms, some of the most stubborn symptoms to treat in cancers, in malignancies, and food-related questions are the most common question that every parent will ask you in the disease trajectory. So some definitions and also some differences between the two. Anorexia means loss of appetite and a poor caloric intake. Cachexia is a metabolic syndrome which is characterized by loss of muscle, and there can also be loss of fat mass. Cachexia is actually more dangerous than anorexia. But you have the anorexia cachexia syndrome, which is anorexia along with involuntary weight loss, and there is also tissue wasting and, of course, weakness that happens along with it. So, understanding cachexia. The disease process itself gives rise to a host of tumor products also and a lot of cytokines also. While these can contribute to anorexia, these also contribute to changes within the body and specifically a catabolic state. And this can be either there will be an inflammatory process, there will be changes in the metabolism, and all of this will then cause downstream effects leading to proteolysis as well as lipolysis. Now, on the left-hand side, you have secondary causes of reduced food intake. So there will be poor oral care. There can be chronic nausea, altered taste because of medications, oral ulcers, any of those things. Then you can have dysphagia, pain, depression, and disuse of muscles. So all these actually are secondary causes of reduced food intake. Can you just give me one moment and I will quickly get back. Okay, getting back, eating and food, of course, we know hold an important meaning for patients and families. And so a loss of appetite and an involuntary weight loss can have a negative impact on the quality of life. Meantime also holds a lot of memories, cultural significance, emotional significance, and many times parents come to us saying that I cannot eat because my child is not able to eat, and especially in cancer, because we put so much of the focus on improving the nutrition. Towards the end of the trajectory, when the child has gone into cachexia, the families will feel that they have failed the child by not being able to reverse this kind of wasting and by not being able to provide adequate nutrition. So just some key differences between these two. Anorexia is most often a side effect of treatment. It can lead to poor caloric intake. It can lead to protein energy malnutrition, but it is reversible when the cause is corrected. Now, cachexia is actually a cluster of symptoms which triggers a process that has multiple downstream effects, so metabolic, neurohormonal, and also an emotional state. So it's a metabolic disorder characterized by increased catabolism, and it is not reversed by food intake, maybe to some extent in the beginning of the cachexia, but later on, once cachexia sets in for a long time, it does not reverse very easily. And actually, the degree of cachexia is directly correlated with the prognosis of the disease. So, the best way to assess and treat is determine the possible causes. Again, treat the treatable, but keeping in with goals of care. It is not going to be feasible or ethical to actually force feed a child who is at the end of life just in order to try and reverse the cachexia. As we discussed, anorexia has numerous causes. Anorexia will not cause cachexia, but it is the other way around. Cachexia can lead to anorexia, which will then further worsen the cachexia and cause a vicious cycle. We've already discussed this. The primary causes is related to the metabolic and the catabolic state, which causes the cachexia, and the secondary contributing factors can also lead to the weight loss. So For us, actually, the thing to focus on is, can we actually treat the secondary contributing factors, because those are going to be the ones easiest to treat for us in anorexia. So principles of management: determine the food intake of the child, its impact on the child's day-to-day activities. What is the potential for reversal here? In later stages of the disease, our focus is going to be patient comfort and reducing patient and family anxiety. So, giving non-pharmacological inputs, such as even if the child is not able to eat a lot, just having the child sit with you at meal times, sit with that bowl of food in front of them, and just allowing the child to pick at it and eat as much as possible also will add to that sense of, okay, togetherness and time spent well with the child. And then, of course, involving an interdisciplinary team, including a dietitian, a physiotherapist, an occupational therapist, speech and language, if you are thinking about dysphagia, and overall cultural and spiritual care, which is provided by the broader community that the family is a part of. We also, especially in adolescents and younger adults, acknowledging distress about body image, fatigue, and functional decline, giving these adolescents ways to express themselves. Adolescents, as we all know, are very expressive, and they will need either group therapy, they may need activities like journaling, art therapy, in order to talk about these things and express themselves. And I think at the end of the day, we need to establish a realistic goal. All the principles that I discussed about when we spoke about TPMs, and how impactful it can be, or how realistic that expectation can be, many of those principles apply here also. Because families will want to discuss feeding through rice tube, alternative parental modes of nutrition, just in order to kind of counteract this cachexia. And it is up to us to then discuss that this is actually a catabolic state which is very difficult to be reversed. So again, an algorithm for management. So a careful, detailed assessment, look at, do a complete history and exam. Initiating environmental change like small meals, comfortable environment, mouth care, discontinuing medications causing appetite suppression, support for emotional distress, making sure that you are actually providing some amount of holistic care, allowing the child to express what is the matter with them, rather than just focusing on feeding. And then pharmacological intervention. Some of the commonly used drugs are actually megestrol and dexamethasone. We don't use the others that frequently. And of course, the most important is discussing goals of care. I think that in communication, there will be a separate sort of subsection on goals of care, and how to discuss this. And because if I start discussing about how to discuss goals of care, it will take a very long time. These are again some dosages. I'm not going too deep into them. There are quite a few drugs, but that are being written, like being prescribed, or being suggested rather, for cachexia, but we don't end up using many of them. Okay. I think somebody wanted a pediatric dosage of megestrol. This is the dosage. If you want, I can send you the presentation also. All right. Okay, one more case. A 4-year-old child with medulloblastoma not responding to verbal commands or painful stimuli since the last 2 days, not taking any food or liquid orally. The family is insisting on IV fluids to improve the weakness. What is your response? Okay, NG feeding can be discussed. Anybody else has other thoughts? Read the case. Oops, sorry. Read the case again. Ensure the child does not have posterior fossa syndrome. Okay. Disease status related. I think that's one of the most important things that needs to be discussed. Family counseling, depending on if it's a progressive disease. Yeah, yeah. If there is a child not responding to verbal commands or painful stimuli since 2 days, what would you think of? I think the point here was to think about this in terms of advanced disease and maybe even a child at the end of life. And then for a child at the end of life, would you offer Ral's tube feeding? Would you encourage Ral's tube feeding? Would you want to discuss the pros and cons of Ral's tube feeding in the in an end of life situation? So these are some of the thoughts to be had. Discuss with family. Most important, discuss with family, establish goals of care. But even before that, basic principle of communication, break the bad news. Let them know that this is likely an end of life situation. There is too little information on this slide for you to directly reach that conclusion of end of life. Yes, the Sykes model of communication. Okay, so these are some of the things that we can tell the family. The body needs less nutrition as it shuts down naturally. Urine output will naturally decrease. Artificial hydration and nutrition can actually cause an increase in the edema, an increase in the ascites, can cause respiratory distress, and can increase the secretions of the child, which will again lead to distress. If family is insistent or feels that increasing nutrition is the best way out, then you consider a time limited trial. The concept of a time limited trial is also something that is used more often in palliative care, sometimes even in intensive care, where we introduce an intervention only for a limited amount of time. We define that limited amount of time. We also define the outcomes that we expect to happen at the end of that intervention. So to say that, okay, you are feeling that he is dull or he is listless because he's not eating much, let us initiate a trial of rice tube feeding or IV feeds or IV fluids for the next 48 hours. At the end of 48 hours, this is what I'm hoping to achieve. I want to see I would like to see this child open his eyes more, interact more with his family, speak more, and try and eat more. If we achieve any of these, then I would also want to go ahead with IV fluids. If not, then I don't think that they have helped the child in any way. So being very clear in your intent when you are giving IV fluids at the end of life or giving RT feeds or any intervention actually at the end of life is paramount, because that is one way in which giving these clear specific endpoint goals is something specific, something concrete that the family can hold on to while they are sort of preparing for this difficult time. Okay, I'm going to quickly end with GI dystonia. Again, this is not something that you will see in most of your children, because GI dystonia quite commonly occurs only in children with severe neurological impairment. It does not qualify for the traditional definition of intestinal failure. I think I must have also sent you reading material related to GI dystonia. You will see that there is temporal relationship with feeding and symptoms. So symptoms occur either sometime before feeds or after feeds or associated with feeds. Feed intolerance can cause malnutrition, primarily because you will end up, the family will end up having periods of cessation of feeds, reduction of feeds, or the GI burdens. The GI symptoms can actually be the burden on the quality of life. Symptoms can be pain, nausea, vomiting, retching, or bowel habit related. And so upper GI causes can be central jam, and so upper GI causes of GI dystonia can be a central damage to the areas of the brain involving the vomiting reflex. So also CNS tumors can cause this. Gastrointestinal dysmotility, including delayed gastric emptying. Some other causes are inappropriate autonomic activation. All this is mainly seen in the context of SNI. So visceral hypersensitivity or visceral pain, secretion clearance difficulties triggering repeated coughing or vomiting, which will then activate the vomiting reflex, emetogenic medication. Lower GI, there will be chronic constipation leading to alterations in bowel compliance, upper motor neuron damage. Again, this is going to be a primarily neurological issue. Autonomic dysfunction, visceral hypersensitivity, intestinal dysmotility, all these are common causes for both upper as well as lower GI. So management of GI dysmotility includes first establishing that temporal link between feeds and symptoms, reduction of 30% in feed volume over 2 to 4 weeks, and then monitor. At this point of time, you may have to do permissive undernutrition. You can simplify the formulas in the form of either giving them hydrolyzed or elemental feeds. More frequent feeding, which is smaller. Other options is nighttime continuous feed with daytime boluses. And blended diet versus commercially prepared. Yes, of course, if you have good elemental formulas, they can be useful, but they can also be very taxing in terms of finances for the child, for the family. Next is watching for constipation and actually treating the constipation, looking to see how position change and effect and how they can affect the symptoms. So can a GRD chair help? Can changing the position, the angle from say 30 to 45 degrees help? Is one lateral position better? Then you have gastrostomy tube venting. If dysautonomia or visceral hyperalgesia is a cause, then gabapentin or clonidine can help. If there is agitation and anxiety that's predominant, then short-acting benzodiazepines. For upper GI symptoms, we have more of prokinetics and levothyroxine helping. Whereas for lower GI symptoms, you can have laxatives and suppositories, and these will be the major pharmacological interventions. I think that was the last slide. I'm going to stop sharing now. That was a very abrupt end, but we have given you a lot of information in the last 1.5 hours. I know that one person wanted to discuss a case. Can you tell us in short what this case was, Tirumala, and how did you manage it, please?
Yeah, ma'am. She was a adolescent girl, about 14-year-old girl with osteosarcoma of the right femur, who had we had just started chemo. I mean, one cycle was over. This was just a second cycle. Even during the first cycle, she had a lot of nausea, vomiting. Actually, the parents themselves, as well as the child, are quite anxious people. So we also took in the help of the psychologist from the beginning itself to, counsel them and all that. And this time also, with the second chemo also, she received olanzapine, palinosetron, and others. And, almost every day she was requiring ondansetron. So, she was like fine, and her counts all recovered. We had discharged her. And again, she came back with vomiting, some low-grade fever. So vomiting and nausea and reduced appetite was the very significant issue. And she almost got admitted to the ICU as well with this nausea and vomiting. So, it was like, I mean, there was no other causes. We did even an ultrasound, and, and there was also, had also lost significant weight, almost 2 kgs in about a month she had lost. And appetite was very much reduced, both during chemo as well as post chemo. She's, like she totally does not take any food. She, has the fear of, that she will vomit. So we thought we'll try Loraz, but we didn't really start Loraz because maybe we should have started like before the chemo itself. But we didn't start. Maybe we are planning for the next chemo. But any more things that we can do to help her, ma'am?
I will also ask Dr. Manjari to give in her inputs, but this seems like adolescent, a lot of peri-chemotherapy anxiety, a lot of family anxiety. I would want this child to, yes, we will need good drug coverage. Dr. Aarti has written that 4-drug regimen helps. I think lorazepam is a good option. I think this girl will need a lot of support. So finding out exactly what helps her in terms of well, one, finding out exactly what her anxieties are. Is it chemotherapy related? Is it disease related? Is it body image related? All of these. And this is a girl who will require a lot of psychosocial support, in my opinion.
Do you have apripitant available?
Yeah, ma'am. We were using even aprepitant as well. Dexa, aprepitant, Palano, Cetron, as well as olanzapine.
So I think what she needs is, as you rightly thought, she needs an anxiolytic so that she's able to sleep and she has that fear taken away from her with a good sleep. And apripitant has to be given 45 minutes ahead of time. And if you're sticking to that, many times they just don't do it, and that's the reason why people will struggle, especially when you're thinking about MAP. That's a double whammy. Yeah.
Okay, ma'am. Okay. Okay. Point noted.
And I mean, given the age and everything, I'm wondering, it's a little bit about finding the meaning of the disease experience for this child. And I think it could well be that there's a lot of psychological, emotional stuff that's going on in the background. So, um, yes, the medication's true, but as well as what is the meaning of this for this girl? Is she fearing that things may not work out? Is it fear of dying, losing control? And then it's about maybe giving her a little bit of control back to herself. One of the non-pharmac methods that I'm aware of is to use the acupressure point. I forget what this point is called. Smriti, is it called the number 7 point or something? That's essentially about two finger breadths below the wrist joint in the midline. Press hard, or use a brace that gives pressure at this point. Sometimes does help with nausea.
Okay. Any more questions? Order of antiemetics with relation to chemo. I think that an oncologist would be better suited to answer that. Maybe Dr. Uparkar, who had given us some tips before, if you would be okay to take
So
this
I
question.
think most of the chemotherapies in any system wherever you work have got either they are some chemotherapies like vincristine, which has got no emetogenetic power. That if the child is vomiting on vincristine, you know that either the child has managed to have obstruction or child has just got anxiety related vomiting. Because vincristine per se doesn't cause it. But then if you're thinking about you're going to give cisplatin, so every drug has got its emetogenetic power, so every hospital should have their SOPs with respect to what is your at what point is your standard treatment is going to get escalated. So you don't give everybody four drugs and give them a whole pharmacy to take on, rather than somebody who can just be sorted with ondansetron should be sorted with ondansetron, but somebody might like cisplatin related nausea, we normally in UK at least we all will give apripitant ahead of time, and then we have free drug regimen which gets built up. On the top of that, if they're struggling, then we just put them on either a drip, a slow standard drip going on of antiemetic. So I think it's not, you cannot give a ballpark figure that start this. It depends on what chemotherapy regimen you are using.
Okay. We are reaching the end of the session. Just going to give 1 minute if in case anybody has any last minute questions, and then I think we will say good evening. Oh, my experience with using Megestrol in children or adolescents. Adolescents, yes, but I haven't used it with smaller children. Overall, my experience of using Megestrol has not been very positive, I would say. I have not found that it has improved appetites to a large extent. Okay, all right. Thanks, everyone. Thank you. Bye. Have a good
Thank you
night.
so much, ma'am. Thank you, Manjari ma'am and Shruti ma'am, for this wonderful session. I request all the doctors to please kindly do the post-test, and as well as the feedback for the session. Thank you so much. Thank you, ma'am.